Hello, my name is Rita Brusco, and I am a board-certified family nurse practitioner narrating this presentation written by Desiree West, a board-certified nurse practitioner, doctorate of nursing practice candidate. I will be presenting thoracic aortic dissection, a global health concern. The learning objectives for this topic will be to define thoracic aortic dissection, identify types of aortic dissection, outline risk factors, detection, diagnosis, and intervention, and to discuss the relationship to global health. I will begin by defining thoracic aortic dissection. The aorta is the largest artery in the body that originates from the heart, curves through an arch in the upper chest, and descends into the abdomen to deliver oxygen to distal organs. An aneurysm is defined as a permanent localized arterial dilation to more than 50% of the normal diameter. A thoracic aortic aneurysm is an enlargement of the thoracic aorta that enlarges over time, resulting in a tear of the inner layer of the aortic wall. Aortic dissection is an emergent, highly fatal cardiovascular medical condition defined by the progressive separation or splitting of the layers of the aortic wall and subsequent creation of a pseudolumen that may compress the true aortic lumen, resulting in the degeneration of the aortic media. Thoracic aortic aneurysms may grow asymptomatically until they rupture, with a mortality over 90%. The true incidence and prevalence of this condition is uncertain. However, thoracic aortic aneurysms have an estimated incidence of at least 5 to 10 per 100,000 person years. According to location, thoracic aortic aneurysms are classified into aortic root or ascending aortic aneurysms, which are most common, approximately 60%, followed by aneurysms of the descending aorta, approximately 35%, and aortic arch, less than 10%. Thoraco-abdominal aortic aneurysm refers to descending thoracic aortic aneurysms that extend distally to involve the abdominal aorta. Anatomically, the aorta is divided into 4 parts. The ascending aorta, which starts from the heart and from which coronary arteries arise. The aortic arch, which bends over the heart and turns towards the posterior thoracic wall. The descending thoracic aorta, which extends through the posterior thoracic cavity in vicinity of the spine. And finally, the abdominal aorta, which runs below the diaphragm. Here I will discuss the types of thoracic aortic dissection. Aortic dissection is classified by the location of the dissection and/or origin of the tear and the expanse of the dissection. The 2 most frequent anatomic classification systems are DeBakey and Stanford. DeBakey classification, which is based on the site of origin of the tear, and Stanford classification, which specifies the involvement or lack thereof of the ascending aorta. DeBakey classification precisely describes the site of the dissected segment or diseased lesion. Type 1 dissections usually originate from the ascending aorta and have the most extensive involvement, including the ascending aorta, aortic arch, descending aorta, and further. Type 2 dissections originate from and are only limited to the ascending aorta. Type 3 dissections originate from the descending aorta after the left subclavian artery orifice and affects the descending aorta, type 3A, and/or distal abdominal aorta, type 3B. Stanford classification helps indicate different management for dissection cases in clinical practice. Type A dissections involve the ascending aorta, DeBakey type 1 and 2, usually requiring swift surgery, while type B dissections only involve the descending aorta, DeBakey type 3, and can be managed endovascularly or medically. Here I will now discuss clinical presentation and complications. The presentation of aortic dissection can vary and depends on age, comorbidities, and complexities. The classical presentation is characterized by an acute onset and severe tearing, pain in the chest or back. The majority type A dissection patients experience a sudden onset of chest pain with characteristics of sharp or stabbing pain, while type B dissection patients present with localized back pain or pain migrating to the abdomen, which suggests the dissection extends to the distal segment of the aorta. The most common presentation of aortic dissection is the abrupt onset of pain in the chest, back, or abdomen. This pain is frequently described as stabbing in nature as the result of the tear in the aortic wall. Computed tomography, also known as CT, is the preferred mode of diagnostic imaging for aortic dissection, and prompt and accurate diagnosis is crucial. CT demonstrates the size, location, and extent of the aneurysm and clearly shows the relationship between the aneurysm and surrounding organs or vessel branches. The most common risk factor for aortic dissection is poorly controlled hypertension. Other risk factors include age, male sex, smoking, obesity, dyslipidemia, chronic obstructive pulmonary disease, aortitis, family history, trauma, and genetic variants such as bicuspid aortic valve, Marfan syndrome, Turner syndrome, Ehlers-Danlos syndrome, and Loeys-Dietz syndrome, as well as pregnancy, postpartum, drugs, and illicit substances. Possible complications of aortic dissection are cardiovascular complications. These include congestive heart failure, myocardial ischemia, and infarction and aortic regurgitation. Myocardial ischemia and infarction results from the compression of the coronary ostium by the expanding false lumen, then causing aortic regurgitation. Aortic regurgitation resulting from aortic dissection is the most common cardiac complication and accounts for 40 to 75% of patients. Here I will discuss guidelines for surgical intervention. Surgical repair of thoracic aortic aneurysms occur at a threshold of greater than or equal to 5.5 centimeters. Surgical intervention should be considered for rapid growth of greater than or equal to 0.3 centimeter per year in a 2 consecutive year time, or greater than or equal to 0.5 centimeters per year in 1 year, and greater than or equal to 0.3 centimeters in 1 year for those with bicuspid aortic valve. In patients undergoing surgical aortic valve replacement or other cardiac surgery with aortic root dilation, surgical ascending aortic replacement is reasonable for ascending aortic diameters of greater than or equal to 5 centimeters or greater than or equal to 4.5 centimeters at experienced centers. Patients with genetic or connective tissue disorders, appropriate thresholds for surgical intervention are greater than or equal to 5 centimeters. Indications for earlier surgery include rapid growth, greater than or equal to 0.3 centimeter per year, family history of dissection, desire for pregnancy, severe valve regurgitation, and patient preference. Surgical repair of a thoracic aortic dissection is an emergency life-saving procedure that aims to prevent aortic rupture, restore normal blood flow, and reduce the risk of death. A sternotomy is performed to access the aorta. The patient is placed on cardiopulmonary bypass to take over circulation and oxygenation during the repair. During hypothermic circulatory arrest, the body is cooled to protect the brain and organs while circulation is briefly stopped to repair the aorta. During resection and grafting, the dissected portion of the ascending aorta is removed and a synthetic Dacron graft is sewn in place to replace the damaged segment. Once graft is in place, blood flow is restored and the patient is rewarmed. Here I will discuss the implications for global health. Thoracic aortic dissections have significant implications for global health due to its high mortality rate, need for advanced diagnostics, and surgical care. Dissections, especially type A, have mortality rates as high as 1 to 2% per hour if untreated, with up to 50% dying within the first 48 hours. Even with treatment, post-surgical complications such as stroke and organ failure can lead to long-term disability. Thoracic aortic aneurysm dissection cases go undiagnosed or misdiagnosed due to lack of access to imaging, limited awareness among providers, or weak emergency room response systems. Global disparities. Survival after thoracic aortic aneurysm dissection varies based on geography. For example, in the US and Europe, early detection and surgical treatment reduce mortality. In sub-Saharan Africa, Southeast Asia, and parts of Latin America, mortality remains high due to delayed access to surgical centers. In conclusion, acute thoracic aortic dissection is a highly fatal medical emergency that requires prompt diagnosis and surgical intervention. The most common presentation of aortic dissection is the abrupt onset of pain in the chest, back, or abdomen. Surgical repair of a thoracic aortic dissection is an emergency, life-saving procedure that aims to prevent aortic rupture, restore normal blood flow, and reduce the risk of death. Thoracic aortic dissections have significant implications for global health due to its high mortality rate, need for advanced diagnostics, and surgical care. For more information, please visit the following resources. International Registry of Acute Aortic Dissection, also known as IRAD, is an association of research centers evaluating the current management and outcomes of acute aortic dissection and intramural hematoma. It was established in 1996 and is comprised of 58 large referral centers in 13 countries. IRAD endeavors to assess the etiological factors, modes of presentation, clinical features, treatment, and hospital and post-discharge outcomes of patients with acute aortic dissection around the world. Next, the Society of Thoracic Surgeons, also known as STS, is a not-for-profit organization representing over 7,200 surgeons, researchers, and allied healthcare professionals worldwide who are dedicated to ensuring the best possible outcomes for surgeries of the heart, lung, and esophagus, as well as other surgical procedures within the chest. Thank you. Included are the references used for this presentation.